Hello, my name is Dr. Peter Stanich. I'm a gastroenterologist here at the Ohio State University Wexner Medical Center. I'm excited to talk to you today about genetics and gastroesophageal cancers. I'm part of our Ohio State GI genetics team. That's me in the middle there in the white coat. And also on the team is Heather Hampel and Rachel Perlman. They are both genetic counselors that I'm lucky enough to be able to work with in our GI genetics clinic. And I'll talk to you about their roles in the clinic and how crucial it is in the upcoming slides. A few disclosures. I do get research support from pharmaceutical companies and from a patient advocacy group, and we have done some research with one of the genetic testing companies, but I do not think that'll be relevant for anything we discuss today. On the agenda is to discuss the clues to inherited cancers and then go over an overview of a cancer genetics appointment and let you know what will happen if that's something that you're interested in or that you're referred for. Then we'll talk about inherited syndromes that are linked with gastric and esophageal cancer. It's important to know that most esophageal and gastric cancers are not inherited. For gastric cancer, it's estimated that 1 to 3% of these are related to inherited syndromes. For esophageal cancer, it's less than 1%, probably less than 0.1% or even a lower percentage that are related to inherited syndromes. Now, there can be familial clustering or multiple esophageal or gastric cancers in a family that relates to a combination of multiple low-risk genes or lifestyle factors, or Helicobacter pylori, which is a bacteria that can live in the stomach and increase the risk for stomach cancer. But all of those are things that we cannot test for in our currently available genetic testing. So what are some clues to inherited cancers? Well, if there's cancer in 2 or more close relatives on the same side of the family, that's something that raises an alarm. If there's an early age of diagnosis of a cancer, if there's multiple cancers at the same time in a patient, if there's multiple rare cancers in a family, or if there's evidence of autosomal dominant transmission, then that also raises our concern. Now, what is autosomal dominant inheritance? Well, this is when someone who has one copy of a trait or has one gene that carries a mutation or a variant does have that condition, and then for their offspring, there's a 50-50 chance that they would inherit the abnormal gene or the normal gene. So for what we're talking about today, autosomal dominant inheritance means it's a 50-50 chance of passing on that genetic trait to your offspring. Or that you, if your parent has it, a 50-50 chance that you inherited it from them. Now, sporadic cancers are on the left-hand side of this slide, and that is the more common cause for cancer, like we talked about. That's usually a later age of onset. There's usually little or no family history of cancer, and these are usually single or one-sided tumors. The reason they're later age of onset is that you can see people with sporadic cancers are born with 2 normal genes, and then over the lifetime, mutations occur, maybe from smoking, maybe from radiation exposure, maybe from bad luck. Then they have 1 abnormal gene, but the cell can usually still function, and then a second hit happens, and then if you have 2 mutations in that gene, then that's when cancer can occur. People with inherited cancer syndromes usually have an early age of cancer. There could be multiple primary tumors or multiple different cancers. There can be multiple generations with cancer, and there's usually clustering of certain cancers. We all have heard about BRCA mutations like Angelina Jolie has, and so if there's multiple breast cancers in a family, we think about BRCA mutations. That's similar with other types of cancer. Now, the reason that people with inherited cancer syndromes get cancer earlier is because they're born with 1 mutation. So all it takes is 1 mutation to occur during their life, rather from smoking or alcohol use or unknown causes, and then that cell can turn into cancer. So basically they're born with 1 abnormal gene, so it only takes 1 mutation instead of those 2 mutations to start a cancer. Now that we've kind of have a background of what we're looking for to make us concerned for inherited cancer syndromes, let's talk about a cancer genetics appointment. These are about 90-minute appointments, so it is a long appointment with lots of information. Starts with a review of the clinical history. That's both the patient's personal history and their family history. We consider the most likely diagnosis. We go over the pros and cons of genetic testing, and thankfully there's less and less cons in today's day and age, but this is something where we want everyone to be able to make the best decision for themselves. And then right in that clinic visit, we order and draw the genetic testing sample, whether that's blood or saliva, if the patient agrees to undergo the testing and if the testing is indicated. And most importantly, the genetic counselors have a very intimate knowledge of the insurance and lab rules. And this is something that we hate to see, but sometimes when genetic testing is done by non-genetic doctors or with providers who don't have this expertise, there can be big bills that are racked up or the wrong testing can be ordered. And that's something that we can very much avoid in today's settings in the genetics clinic. And then the most important part is you get post-result counseling. Once the testing is completed, the genetic counselor will call you, talk through the results, and make sure you know what this means for you and your family. So what are some of the benefits? You get accurate counseling on risk for future cancers, and that's both another cancer in the same organ, as well as risk of other cancers in different organs. We do discuss potential results prior to testing. We make sure that people are aware that the genetic testing can come back showing a syndrome that may have major effects on that person's life and their family's life, that may come back unremarkable, and we may have to give recommendations based on the family history, or it may come back in a gray zone, what we call a variant of uncertain significance. And genetic testing is not a yes or no condition. Sometimes we come back with results that we just don't know what to do with now. And that's very important to make sure people know those options before they get into the testing. But what I have found that most people find is the highest yield part of genetic testing is you can do predictive testing for at-risk family members. And we'll talk about this a little bit later in this talk with a case example. But this is something where the result may not be as helpful for someone going through cancer at the time, but the ability to have their family undergo testing and either know that they're not at risk, or if they are at risk, they could start screening early, is something that really brings a lot of satisfaction to the patients, and it is really helpful for the family. Now, there are a lot of myths about genetic testing, but hopefully I can dispel some of those. This is something that is very commonly done now, and it's very easy to obtain. I mentioned this earlier, but it can be done from blood or saliva. Very rarely, we have to do something called a skin culture, where a skin sample is taken and can be grown in the lab to give us the tissue that we need. But that's really only done if someone's had a bone marrow transplant. Usually in the office, we draw blood, but saliva is becoming more and more of an option. And especially in today's day and age with the COVID-19 concerns, we're still able to do genetic testing because we can have labs sent to people's houses, and they could spit into the sample collection device and send that into the lab without ever coming into the office. So even though things are very different right now, we have been able to go forward with this for people who need it, which is great. The other primary concern is always cost. So now this is very commonly covered by insurance. If not, the out-of-pocket price is usually $250 or less, especially if it's ordered through a genetic counselor with lab knowledge. This is where sometimes doctors without a lot of genetics experience will order through much more expensive labs, and it's very unfortunate. So, it is something that, 10 years ago used to be $5,000 or $10,000. So $250 is pretty remarkable. Now, thankfully, a lot of labs are testing Medicare and Medicaid patients for free, which is very, very awesome, because those are insurance. That public insurance often is very slow to incorporate new tests. So this is something that's allowing us to test patients who need it with these insurances while we wait for those rules to change. And then something that we're very excited about is now that there is free family testing after a positive result for many labs. And so this takes down a lot of barriers to get other family members tested. One thing I do need to mention is GINA, which is an act of Congress that prohibits genetic discrimination. This was a major step forward for genetic testing. It does protect patients from employment and health insurance discrimination based on their genetic testing results. The one aspect that is not protected is life insurance. We're not sure that that changes because usually there's a family history that may impact life insurance anyways, or a personal history. But if you're considering genetic testing, the life insurance aspect is one thing that you may want to pin down before you come and see us in the clinic. But I would urge you not to let that delay necessary genetic testing that you or your family may need. At this point in time, we very often do panel testing where we test multiple genes at the same time, often 47 or more genes. Thankfully, with current technology, it's done all for the same cost and all for the same time period. And usually we get results back within 2 weeks, which is pretty remarkable. If a gene mutation is known in the family, we'll often only test for that single gene or even that single gene change in the at-risk relatives, unless we have a concern for 2 syndromes in the family. This single site testing is free at many labs for 90 days after the initial test. Or if the test was done, a long time ago, that single site testing can often be done for as little as $50. So that is something where family members, even if they're not of age to have the testing now, it should remain very accessible in the future. Now, genetic testing results can also help determine treatment options. And this is something where the person going through the testing can also have some benefit currently, as well as helping predict their future risk. We know Lynch syndrome patients respond very well to immunotherapy treatment options, which is a major advance in cancer treatment in the last couple of years. And similarly, BRCA patients respond to PARP inhibitors. And these are just 2 examples, but this is one of the additional reasons why genetic testing is coming to the forefront now, that not only is it predictive for family members, but it can also impact treatment decisions. Now, who should be seen in genetics? The best candidate for genetic testing and for the genetics appointment is a person most likely to be affected. Now, what does that mean? That usually means a person with cancer or the person in the family with cancer at the youngest age. If that person is unavailable or unwilling, then we would prefer to see the closest relative to them. The reason for that is an unaffected patient cannot be a true negative if they are the only person to test in the family. To put an example with this is if we get someone, let's say there are 3 siblings and 2 siblings died of gastric cancer when they were 40, and we're seeing the 75-year-old sibling who's never had cancer in the office, we would offer that person genetic testing. But if that's negative, that doesn't mean that the 2 other people who had markedly different health histories did not have a genetic mutation that our patient didn't inherit. So that doesn't help the family as much as it just helps the person sitting in front of us. And even then, we can't totally clear them because we don't know if there is something to be found. Now, the flip side of that is if we get someone who's a 40-year-old who has gastric cancer and we test them and they're positive, and if we test their 45-year-old sibling and they're negative, then we know that 45-year-old does not have that risk that's of the genetic mutation, and they can go back to average risk screening. So with all that being said, when should a genetics referral occur with gastric and esophageal cancers? For gastric cancer, the general rules are if there's 2 or more cases of gastric cancer in a family, with 1 at age less than 50, or 3 or more cases of gastric cancer in close relatives at any age, or diffuse gastric cancer at age less than 40. And we'll talk a little bit more about diffuse gastric cancer, but that's a specific pathology finding. If there's a diffuse gastric cancer and lobular breast cancer in the same person, or if there's a diffuse gastric cancer and lobular breast cancer in a family, or if there's gastric cancer and other Lynch syndrome associated cancers, those are all families and people that should come and see us in the office. Esophageal cancer, there's no formal recommendations for people who should be referred to genetic testing, since that the rate of these being related to inherited syndromes is so rare. But I will just add, and we'll talk a little bit more about why, that if there's multiple cases of a squamous cell esophageal cancer, that's a less common type of esophageal cancer in the United States. It's usually more in the upper or middle esophagus. But if there's multiple of those squamous cell esophageal cancers, that's something that there is a condition that you should be assessed for that we'll talk about. Hereditary diffuse gastric cancer is due to CDH1 mutations. This is the most common syndrome associated with stomach cancer. And it's not just any stomach cancer, but it's this diffuse gastric cancer phenotype. And so diffuse gastric cancer is a specific finding on pathology. This is something that all oncologists and surgical oncologists should be familiar with. But it is something where everyone has to look out for themselves and their own family, and sometimes this is overlooked during the intense treatment or surgical planning. If someone has hereditary diffuse gastric cancer syndrome due to a CDH1 mutation, there's a very high risk for gastric cancer. That's 70% in men and 56% for women. And for women, there's a high risk for lobular breast cancer. That's a less common type of breast cancer, and that's up to 42%. The tricky thing about this syndrome is that screening endoscopy or endoscopic ultrasound, which is a specialized endoscopy where there's an ultrasound on the tip of the scope, and we can look through kind of the stomach wall. Neither of those have been found to be beneficial. So this is something where we recommend prophylactic stomach removal or stomach removal before we know there's cancer at age 20 to 30. But with that very high risk for stomach cancer, we know that it's helpful in these families. So just to state this again, we do recommend testing for a CDH1 mutation when there's 2 cases of gastric cancer in the family, and one of them is confirmed diffuse phenotype. If there's a diffuse gastric cancer at age less than 40, or if there's a diffuse gastric cancer and a lobular breast cancer in the family with at least one under age 50. And then if there's 2 or more lobular breast cancers in a family or in a person, we would consider this. Or if there's a diffuse gastric cancer and a cleft lip or palate history, that's also something we would consider testing. Now, I do want to show you a case of how this can come about in a family and how this can be helpful. So there's a 52-year-old female that we saw, and she was diagnosed with stomach cancer or gastric cancer at age 51. The pathology when she had her stomach removed, was a poorly differentiated carcinoma with signet cell ring features and a diffuse infiltrative pattern. So there's that word diffuse, like we were talking about, that is kind of a tip-off. She had foundation medicine testing, which is where they take part of the tumor and do genetic testing on that, looking for treatment targets. And that found 2 CDH1 mutations in her gastric tumor. So again, I mentioned this foundation 1 or similar tumor genetic testing isn't looking in the bloodline like we do in our cancer genetics clinic, but it can give us some hints. And when we saw these 2 CDH1 mutations in the tumor and we looked at the pathology, we were concerned that this patient may have hereditary diffuse gastric cancer syndrome. We were then able to see her in clinic and do genetic testing, and it did show that there was germline or inherited CDH1 mutation. And then we're able to test family members. And for the family members who tested positive, we could start with upper endoscopy and biopsies and start discussing surgery. And then even better for her siblings and children who tested negative, we told them they didn't have to worry about the stomach cancer that had happened in their mother or sister. Moving on to another syndrome associated with stomach cancer, there's a condition called GAPS, or gastric adenocarcinoma and proximal polyposis of the stomach. This is very newly described. There's only a few families described with this, and so this is something that we could test for, but still very rare. And it's pretty obvious when this happens. So there's 100 or more proximal polyps in the stomach, and in this picture D, you can see this is an endoscopic picture where the camera goes in and is doing a U-turn, or kind of like a candy cane, and looking back at the beginning of the stomach and the middle of the stomach, and you can see all of these small polyps. And then the end of the stomach, or what we call the antrum, which is E, there are no polyps. And when you have that characteristic finding, that's something that you should start thinking about, this GAPS syndrome. And it's not very well described yet, but we do think the cancer risk is very high. Now, there are some other genetic syndromes associated with stomach cancer that I want to mention, but none of these have gastric cancer as a primary finding. So there should be other, fairly obvious clues to this, but certainly a stomach cancer could be the first thing that pops up in a family, and I want to make sure that you all are aware of this. There's a condition called familial adenomatous polyposis, or FAP, and a very similar condition called MUT-YH associated polyposis, or MAP. These are associated with very, very many colon polyps or large intestinal polyps that are called adenomas. There's usually over 100 and usually over 1,000, but at least 20. That's usually the first finding, is that people present with bleeding due to all of these polyps. The gastric cancer in these conditions, the risk is less than 1%, but that does seem to be increasing, and we definitely watch the stomach in these conditions. There's other polyposis syndromes that are associated with hamartomatous polyps, which is a different type of polyp that can occur in the stomach and the large intestine. These conditions are called Peutz-Jeghers syndrome and juvenile polyposis syndrome. These are both unusual, but at a big cancer center like we have at Ohio State, we do have multiple patients with these conditions. Peutz-Jeghers syndrome has a gastric cancer risk that's up to about 29%. The characteristic finding for this is dark spots on the lips, and here's an example. These are pretty unusual unless you have Peutz-Jeghers syndrome. So that is something where, if someone has a stomach cancer and they have these dark spots on their lips, we definitely want to know about it and do further testing for them. And then juvenile polyposis gastric cancer risk is about 20%. Lynch syndrome, this is the most common inherited cause of colon cancer and endometrial cancer. For colon cancer, this causes like 3 to 4% of colon cancers, which is pretty common. The gastric cancer risk varies by the mutation type, ranges from 5 to 16% for the higher risk genes it causes to less than 1% for the lower risk genes. But this is why for the referral recommendations, we say if someone has stomach cancer and there's other colon or endometrial cancers in the family, this is something we definitely need to consider. And then there's Li-Fraumeni syndrome. This is a very severe cancer syndrome. Is associated with breast cancer and sarcomas or muscle or bone cancers at usually age less than 30 years. These are very severely affected patients and families. The gastric cancer risk is 2%, although some places say it's as high as 5%. Definitely not a predominant factor, but something that can be associated. This is a slide just kind of summarizing what we've gone through from a fairly recent paper on familial gastric cancer. This is just something that you may want for your records, or if you want all those slides in one place, but nothing different that we need to talk about that we haven't already discussed. Now we'll move on briefly to genetic causes of esophageal cancer. There is a condition called tylosis. This is very rare. There's only a few families identified worldwide with this condition. We do know that it tracks mutations in the RHBDF2 gene. There's a very high risk of squamous cell esophageal cancer. Up to 90% of those affected will have esophageal cancer, at least in one of the few families identified. Another finding that goes along with this and allowed for identification of these patients even before genetic testing was available is that these people also get very, very thick skin on the palms of their hands and soles of their feet. And you can see a picture of one of my patients that's even after pedicures, you just get this very thick skin layer that these families know about, and we're the first people to kind of pick up that this predicted that esophageal cancer risk. If a family is identified with this and the person's at risk, we do recommend upper endoscopy starting in the 20s. That's the only known genetic cause of esophageal cancer at this time. Now, what are we doing at Ohio State Genetics? At this point, we are doing universal testing of gastrointestinal tumors that includes gastric and esophageal cancers with immunohistochemistry. What immunohistochemistry, or IHC, is is that's the initial screening test for Lynch syndrome. It was previously only done on colon and endometrial cancers, and actually all of that early work that showed that this universal testing of colon and endometrial cancers was beneficial was done here at Ohio State by Heather Hampel, who I work with in GI Genetics Clinic, but she is, the worldwide leader in universal tumor testing for Lynch syndrome. We were previously only doing that in colon and endometrial cancers, but now we're doing it in all GI cancers. That's because there is a study that came out that showed that that characteristic finding, what we call microsatellite instability or abnormal IHC, is associated with Lynch syndrome no matter where the tumor is at. Now, how much difference does this make for gastric and esophageal cancers? It's not a game changer, but it's definitely something where if Lynch syndrome families are out there, we want to find them. And you could look at this study for gastric tumors. They found 13 out of 211 gastric tumors had abnormal testing. And of those, 2 out of the 13 were found to be related to Lynch syndrome. Now, 2 out of 211 cancers is a pretty low rate, but for those 2 families, this makes a world of difference. As we know that we have good treatments associated with Lynch syndrome and very effective surveillance and screening to prevent cancer in these patients. Esophageal cancer did have some abnormal screening, but none of their patients were associated with Lynch syndrome. But you can see those are still low numbers. And so the benefit of this is still yet to be found, or I would say is yet to be determined, although all these families that we find were really benefiting not only the patient, but maybe more specifically the family. We're also reviewing all Foundation 1 or tumor genetic testing results to look for mutation signatures suspicious for hereditary conditions. So I did show that example of a patient that was here at Ohio State where we were able to identify the CDH1 mutation in the family based on that tumor testing. And so this is something that we're also watching very closely so we try and miss as few of patients as possible. Now, just in summary, we know that most gastric and esophageal cancers are not inherited. We know that genetic testing is cheap and widely available. And if you or someone in your family or someone you know of you think would qualify, we definitely recommend talking to your doctors about it. We know that when genetic syndromes are identified in a family, it has a large positive impact. And as I mentioned, if you are concerned that your family may be at risk, then you definitely need to talk to your doctor about this and they can refer you to see us at Genetics. And with that, I'd just like to thank you for your attention and your time. I'm happy to answer any questions or help facilitate any referrals if they're needed. You can call Genetics office at 614-293-6694 for appointments. We do take self-referrals, and so that is something where if you're interested and your doctor doesn't know how to set it up, or you would, or if you just want to come and talk with us and kind of cut out talking to your doctor about it, that is something where you could set up that appointment, although we do recommend keeping your doctor in the loop, obviously. And then I am on Twitter. I'm at Doc Stanich, if that's something that you want to follow. Usually post updates about cancer genetics. And so just something in today's day and age that can be important to connect with patients. Thank you again for your time, and I look forward to any questions if they arise.